Okay, we have about 5 minutes until we're going to report on our breakout sessions. That is very loud. Woo.
Testing 1, 2, 3. Testing 1, 2, 3. Can anybody hear me? Testing 1, 2, 3. Testing 1, 2, 3. Testing 1, 2, 3. Testing 1, 2, 3. Okay, stand by. Testing 1, 2, 3. Testing 1, 2, 3. Testing 1, 2, 3. Testing 1, 2, 3. All right, but you're saying this is really, really low. Check. Check 1, 2. Correct. We are still on breakout session. We will get, they just gave a 5-minute warning, so we'll be starting back up soon. Check 1, 2. Check 1, 2. Check 1, 2, 3. Check 1, 2, 3. Check, 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 check. Check 1, 2, 3. Check, check, check. Check, check 1, 2, 3.
Okay, we're going to go ahead and get started. If one of the representatives from one of the groups wants to come up and start, that would be great. Thank you. Okay, so what did you guys come up with as your biggest barriers to retention? Okay.
I live in a very rural area. Some of my patients come an hour and a half, 2 hours away, and they have a lot of socioeconomic issues, don't have a consistent way of traveling to our site, so dealing with those types of barriers. Appointment cancellations at the last minute, and they're, with their standard of care visits, and then not being informed that they, have been changed from the clinic, that kind of thing. And then also, our limited time as study coordinators, and when we're on other studies, you're allocated a certain amount of time to your different studies, and sometimes that's not always consistent with the amount of work that you need to do with that study. So those are some of our barriers.
Okay. And then how do you primarily communicate with your patients? Phone, email, both?
For me, mostly by phone. I think that's pretty consistent. Okay. Email's a little bit difficult for some of my patients, especially. So.
Yeah. Okay. And then, have you had anything that has worked for you in terms of retention?
Having the PIs more involved and coming in to the visits and speaking with them at each visit and talking to them too during their standard of care visits as well. The ones that we talked about as a group that we've been able to retain and stay within the study over years are ones that are, their disease process is a little bit further along. They're having to come in every 2 and 3 months for their standard of care visits. So it's a lot easier to capture those. I know for a lot of mine that are, their follow-up phone call visits, I'm actually able to do it in person because they're coming in so frequently. So those are, it's easier to keep those patients in versus ones that are healthier and they may be coming in once a year or every 9 months or so. It's a little bit more difficult to get those patients in and to keep them.
Okay. Any specific examples you guys want to share, or about certain patients or like certain situations you found ways to overcome, or not so, that's just general stuff?
For me recently, a lot of my patients are Medicaid patients, and I went through a process of finding resources for every county that we service, and being able to give that out to parents so that they can be able to find transportation through Medicaid services so that they can be brought in from these other areas to our clinic.
Oh, that's great.
That's a free service.
That's great. Okay, thank you. Next group, anyone?
Okay, I started with my biggest problem, which is my kids turning 18 and aging out and losing contact with them. And sometimes you're at the point where you think they're coming back, and also the doctor's like, no, they're transitioned, and they didn't tell you. So you haven't had that conversation about how you're going to continue their participation. So a great suggestion that I'm going to start right away. I always reconsent them when they turn 18 to be in this study, have them sign a release of information for our adult hospital so that I can work with the nephrology team there about appointments. Obviously, I still am calling them, but if they could let me know when the kiddo's coming in, then I can try to coordinate with visits over there. The team from Canada, I'm so impressed. They have so many patients, and they had no trouble with retention. So we were mostly picking their brains for what they did. But and the other problem I have is phone call visits, retaining them for that, and their biggest thing, which is obvious, but is always not easy to do. Start early in the window. Make sure you're starting that contact as soon as you can. It's not so soon after their last visit, but starting early enough. They do this great thing that they schedule their phone visit at the one before, so if they see them in person, then they schedule that phone visit. I've never done that. I'm like, it's kind of like, I'll call you sometime in March. And then all of a sudden it's April and I've missed the window. So scheduling that, writing down kind of at recruitment, like what days and times are their best available times to have a phone call visit. Like I only work on, I don't work on Mondays or whatever. And scheduling that so that they're most available to do it. I tend to, if I can, see my remote visits in clinic if they're there. If it's a window that I'm going to do a phone visit, I still do it in clinic because it just kind of reminds them that they're still in the study, and I can pass them a newsletter if it's been approved since the last time I saw them. So I think that helps with, again, just kind of engaging them. And then another one of the things that they were able to do in Canada is that they can offer patients to come in a week before their clinic visit and have their labs done, and then they can do their cure visit at that time as well. And so that just, all this, I think, just kind of comes down to coordinating, getting these patients to call you back or come and see you, and managing that. So whatever you can do to make it less burdensome for them seems to be a lot of what we came up with. Miss anything? Anything else?
Okay, thank you. That's very helpful. Okay, next group.
One big issue is distance, because some of the sites see patients from 3 and 4 hours away, and then they wind up going to satellite sites for their clinical care, and there's no way to really coordinate the research visits at those satellite sites. So that's like an issue that really almost needs to be discussed at consent. I know some of the sites also that we've discussed in the past are more like referral centers, and people will go there for a biopsy, but then don't go back for clinical care, and that's really probably not the best patient to recruit to a study like this, except as we discussed, like the membranous patients and the hard to find. Also the patients that go into remission, as we've discussed already, those are hard, but maybe even though like the coordinators will call them and tell them you're still very important, even though you're in remission, we still want you to come back. I think maybe a discussion with the parent, if it's a kid, or with the patient from the PI, from the doctor, may have a little more heft. And aging out at age 18. They seem to, a lot of them just disappear. So
Okay.
That's also an issue.
And so does that also cover your strategies to retain? Is there anything you guys have done that has helped overcome some of that stuff?
Emailing the patients, but
Yeah.
a lot of the patients, if they don't respond to visits or emails, you just have to kind of look when the next visit is and try to catch them.
Okay. All right. Thank you.
Anything else?
With our group, we had both pediatrics and adult. In the adult population, some of the barriers were actually getting them to stay on the phone long enough with you to do the remote call, being able to get a hold of them. Some of the strategies that people used that were very successful was sending cards out, where they actually had the PIs actually sign the cards themselves, the docs actually sign the cards themselves, so that they felt like that they were truly engaged in the action. My group, I have pediatrics, and so we're getting ready to have about 5 of them. They've turned 18. We're transitioning them slowly. We've done the same thing of having them, sign under consent and stuff. But where we are, we do not have an adult participating in the study. So trying to work out how that's going to work, who they're going to go see, how we're going to keep them in the study is very fluid right now. Our pediatricians actually will see them up until they're about 23 if they so choose. If they want to transition earlier, they can, but they aren't forced to transition at 18 or at 21. They do have the option to stay at 23, so that's helpful. We have a large geographic area, so someone's not going to come for more than one visit if they don't have to. So tying everything to a clinical visit is imperative for us to be able to do. So those are some of the issues. Mainly it's the transition. For me, it's the transition to an adult setting and how we're going to be able to pull that one off. So,
okay. Thank you. Any other groups?
Hello. Hi, everyone. Our group actually cares for both pediatrics and adults, and some of the barriers that we identified at our sites were time, money, and then also distance, which it sounds like mostly everyone is having similar issues. As for money, I think, and it kind of goes into play with distance, sometimes the stipends aren't necessarily covering the money that patients are putting in to come far distance. So sometimes that can be kind of a burden for patients who maybe necessarily can't afford to spend the extra gas or, you know, run their car the extra miles. And then just something else is being able to get a hold of these patients. I know some people in our group are having issues with those transitional patients and patients that are like in the early 20s because they're going off to college and they're not coming back and they don't come to their visits. So that could be also something where, you know, time and money is also an issue, so really just coordinating with them. Something that we talked about for methods that may help with these kinds of issues are communicating with people in a way that they like to be communicated with. Our sites in particular have Epic as their electronic charting system, and we do have a pretty large patient population that uses MyChart and really likes MyChart. So we've talked about doing some of the follow-up type questions, getting those IRB approved, the format for MyChart so that they can just respond in their MyChart. And then also the cards and sending out cards and newsletters. I think just making sure, because a lot of sites, I know our site has a whole nother set of IRB approvals, so just making sure that we get those way ahead of time so that we can make sure we get them out to patients. So,
okay, thank you.
So one of the biggest barriers that we have, I'm actually from Columbia, so most of our patients are adults, is that we don't have, I think we should allow visit flexibility across entire sites because every site operates differently and the method of communication is all different. So I don't think sticking to one way of doing a visit schedule is applicable to people. Like for example, most of our patients are second opinion, so once they come to the clinic, they don't want to come back if they're in remission. So doing like a one in-person mandatory in-person visit won't work at Columbia. And I really think the data from the Patient Advisory Council Board is very, very skewed because obviously these patients were selected because they were very compliant, but that's like I really think that's like less than 10%. So if you guys really want a proper reflection of how the patients feel about the study, then I think it's important to take a short survey during our in-person visit. And I mean, let's make the questions very short because it'll be up to the coordinators to tabulate the data. So if we just ask the patients who are in the study what they really feel about, how they feel about it, I think that would be a really true reflection because the biggest complaint, at least from Columbia, is that the patients do not like the amount of blood collected. That is #1 complaint from all of our patients. And return of results would be very, very ideal. And statistically speaking, it will be like, 2% of our patient population with the positive results, and that's what is being returned, not the negative results. So I think the PI should really force to have these genetic results returned. And also engaging the coordinators, I'm not sure if the coordinators have access to Transmart, but I think it would be very nice if the coordinators have access to these data because we're the ones who collected them, and I think all the coordinators have enough clinical background to fathom what we've collected and what kind of prognosis we can deduce from these data, so it'd be nice if we can have the access. And we have some pediatric patients in Columbia, and transitioning hasn't been a very big issue because I actually read that it's a nationwide trend for pediatric patients to continue seeing their pediatrician over the age of 18. And actually in Columbia, we have like 30-year-olds coming to a pediatrician. So frankly, that hasn't been a really big issue. We have 19-year-olds coming to see a pediatrician, so that hasn't been an issue. But yes, like the visit flexibility, returning the data, and coordinators having access to the data we collected would be really wonderful.
Thank you very much. Okay. Anybody else? Did I get everyone? Okay. So this information is especially important. I know we have that survey to fill out as we go forward into CureGen 2.0, because like I said at the beginning, if we don't follow these patients, we're not going to see their outcomes. We're not going to achieve the study goal. It doesn't meet the criteria of a longitudinal study. So, okay.
Yeah, I think that we have a coordinator work group, so that met once to give coordinator suggestions to the DCC and then to report to the protocol review work group. But maybe we can think of having this coordinator work group calls happening also beyond CureGen 2.0 to allow coordinators to be more informed and more engaged and to give suggestions. I feel that a resource for coordinators should be important to allow them to have more information and this way to keep patients engaged. The communication between coordinators and patients is very important, and if the coordinators are engaged in the study and they are informed about the study, they can release this information to the patients and keep them engaged in the long term. So maybe we should think about the resources for coordinators too.
I just wanted to piggyback on what they were saying. I think that a coordinator committee is a very valuable thing that we should look at. I initially suggested the idea of just having an MWPNC coordinator committee, but I think those of us that are pediatric sites can also learn from our adult counterparts. So really think about if that is something you would be willing to participate in moving forward. I think it's important for coordinators to have a voice because you guys are the ones that are running the study on the ground. So you know that visit windows can be an issue. You know the volume of blood really does impact our pediatric families, and they do have blood draw volume concerns. So I think the suggestion of a study-wide participant survey is an excellent one. And I think that is something we should pursue moving forward. And I think the things that come out of you all brainstorming today don't happen until we get you in a room. But maybe if we can have a coordinator committee that meets, you know, every once in a while on the phone. We know you guys are busy. We know you have large study loads. But if your voice can get out there, then maybe we can make this study a little bit less burdensome for you to coordinate. Does anyone else have any other comments or questions before we wrap up the session today? Anything you feel like we didn't quite answer for you or you'd like to revisit?